Welcome to the Funnel Effect. We are diving deep today into what is, well, arguably the most sophisticated and powerful way modern medicine has found to assess the functional health of your heart muscle.
It really is. It's an area that has fundamentally changed cardiac diagnosis, moving us, beyond some of the decades-old metrics we used to rely on.
Absolutely. And just so everyone knows where this insight comes from.
Right. This deep dive is based entirely on the state-of-the-art review, Myocardial Strain Imaging, Theory, Current Practice, and the Future. It's authored by Otto A. Smyseth, Oliver Reiter, Marta Kvijic, Ladislav Valkovich, Espen W. Ramey, and Jensua Voigt.
That's quite the lineup. Represents really the definitive consensus in this field. So our mission today is to unpack myocardial strain imaging. We want to understand the theory behind it, look at the latest technologies, things like speckle tracking and advanced CMR.
And crucially, show you why this way of measuring the heart's deformation is just dramatically more sensitive than the traditional ejection fraction, or EF.
Exactly. We're moving beyond just looking at how much volume the heart pumps.
To actually quantifying the mechanical work. I mean, the heart is this incredibly complex muscular pump, right? And strain imaging lets us access the fundamental function of the muscle fibers themselves, how well they shorten, thicken, and lengthen.
And if you take away just one thing today, it should probably be this. The core clinical parameter that really drives nearly all modern diagnosis in this area is global longitudinal strain, or GLS.
That's the cornerstone, absolutely. GLS, which today we typically measure using speckle tracking echocardiography, or STE, well, that's the single most widely adopted clinical metric.
Why is that?
Because it captures subtle dysfunction much, much earlier than pretty much any other non-invasive parameter we have. Understanding GLS is, frankly, prerequisite for modern cardiac risk assessment.
Okay, let's get into the language of mechanics here. When we talk about strain, it's a concept borrowed from engineering, isn't it?
Yeah.
Where did it start, and why is it the right term for heart deformation?
You're exactly right. Strain comes straight out of continuum mechanics, the science of how materials deform under stress. It describes the change in shape of any structure.
Like a bridge beam or...
Or, in our case, the heart muscle. When we apply it to the myocardium, we're essentially quantifying how much the tissue itself shortens or thickens during contraction and relaxation.
And the key thing is, it's not the absolute length we care about, but the relative change, right, as a percentage.
Precisely. In cardiac imaging, we overwhelmingly use what's called the Lagrangian strain description. The calculation itself is quite simple. It's just the change in length divided by the reference length expressed as a percentage.
So if a segment shortens by, say, 20%.
Then the longitudinal strain is negative 20%. The negative sign just tells us it's shortening. Positive would mean lengthening.
Okay, so defining that reference length, the baseline, seems incredibly important. If you get that wrong.
Oh, it's everything. That reference point, which we call L dollars or sometimes T dollars, is the length of the heart muscle at end diastole.
The fully relaxed state.
Exactly. It's the most consistent and physiologically stable baseline we can use for comparison. Contraction begins from that end diastolic position, so it's our 0 point.
I see. Now, the source mentions an alternative, the Eulerian description. You said that uses the deformed shape as the reference. How would that work?
It's historically interesting because it was used when strain was calculated differently by integrating strain rate. But clinically, it complicates interpretation quite a bit.
How so?
Well, using the Eulerian approach means your reference point is constantly shifting as the heart deforms. It's much clearer, much more robust to compare the contracted state back to that single maximal relaxed state. Lagrangian strain anchors everything to that fixed, reliable baseline. Makes comparing studies much easier.
Got it. Okay, let's think in 3 dimensions. The heart muscle doesn't just shorten one way. It shortens, it kind of cinches in, and it thickens. So we need measurements for all 3.
That's right. These are the 3 orthogonal normal strains of the left ventricle, the main pumping chamber. First, there's longitudinal shortening. This runs along the long axis, from the base to the apex of the heart.
And this is the one that gives us GLS.
Correct. This is the one we prioritize clinically, leading to global longitudinal strain. Then you have the squeeze around the perimeter.
Like tightening a belt.
Exactly. That's circumferential shortening, measured around the short axis. And as we'll discuss later, this movement is actually the biggest driver of how much blood gets pumped out the stroke volume.
Interesting. And the third?
The third is the movement perpendicular to the wall. Radial thickening. Because heart muscle tissue volume is basically conserved, when it shortens in 2 directions longitudinally and circumferentially, it has to thicken radially.
Okay, so longitudinal, circumferential, radial, but those capture the main shortening and thickening. But the heart's motion is more complex, isn't it? It's a twisting motion.
Yes, absolutely. That brings us to the three shear strains. These describe the more complex 3D aspects, the twisting and sliding of myocardial layers relative to each other.
Are these used as much clinically?
They're less commonly reported day to day, but they are important physiologically. The most clinically relevant one is the circumferential longitudinal shear. We usually just call this twist.
Twist. Can you break down the mechanics of that?
Think about wringing out a wet towel. Twist describes the difference in rotation between two different short axis planes of the heart, usually the apex, the bottom tip, and the base, the top part.
So they rotate in opposite directions.
Exactly. During contraction, the base rotates clockwise and the apex rotates counterclockwise. This twisting generates torsion, which is actually vital for efficient heart function.
Fascinating. The source mentions two other shear strains, too. What are those?
They describe motion between the different layers of the heart wall itself. So circumferential radial shear measures rotational differences between the inner layer, the subendocardium, and the outer layer, the epicardium. And radial longitudinal shear quantifies differences in the long axis movement between those same inner and outer layers.
Why are these less common in reports?
Honestly, they're just technically quite challenging to measure accurately and reproducibly with current clinical tools. Plus, since all the heart layers are connected or tethered, the main dysfunction often shows up first in those three normal strains we discussed. So clinically, we tend to focus on twist for rotation and the three normal strains for shortening and thickening.
So after going through all that mechanical complexity, the big question is still, why bother with all this when we have LVEF, the ejection fraction? What does strain give us that EF doesn't?
That's the crux of it. LVEF is fundamentally a measure of volume change. It gives you one global number. Strain, on the other hand, is a tissue measurement. It tells you about the muscle itself.
So it's more fundamental.
In a way, yes. It offers complementary information. It lets us quantify subtle, regional, or segmental function that LVEF, being a global average, just smooths over. He could have a normal LVEF, but GLS could be severely impaired because one specific area is damaged.
Right.
Plus, strain metrics aren't just for systole, the contraction phase. They help us assess diastolic performance, the relaxation phase too, and we can apply these techniques to all the heart chambers, the left atrium, the right ventricle, as well as the left ventricle. It gives us a much more complete functional picture of the entire heart.
Okay, so measuring this deformation accurately obviously needs some pretty high precision technology. Let's trace how we got here. What were the very first methods, the ones that set the gold standards?
Well, the absolute foundation was laid way back in cardiac physiology labs decades ago, using invasive techniques, really invasive.
Like surgery.
Essentially, yes, in animal models initially. They would surgically implant tiny ultrasonic dimension crystals directly into the heart muscle, or they'd implant little radiopaque markers, basically tiny metal beads in a grid pattern across the muscle.
Wow. And how do they track these tiny things inside a beating heart?
Using high-speed biplane cineradiography, essentially, X-ray movies from two angles at once. This allowed researchers to track the 3D movement of those markers and derive the true deformation of the myocardium.
So those invasive methods became the benchmark.
Exactly. They became the preclinical gold standards. Any new non-invasive method that came along had to be validated against these techniques.
Which brings us to the non-invasive era. Cardiac magnetic resonance, or CMR, came next, right? How did that work initially?
Yes, CMR was a huge leap. The earliest methods introduced back in the late 1980s were revolutionary. They used something called tissue tagging, or sometimes spatial modulation of magnetization.
Catchy name.
Huh, maybe not. But the technique was clever. They used specific radiofrequency pulses to temporarily alter the magnetic properties of the heart tissue itself, creating a visible grid of dark lines, or tags, right inside the heart wall.
Ah, so it basically replicated the idea of those invasive metal markers, but non-invasively using magnetism.
Precisely. You could see the grid deform as the heart contracted, allowing for 3D strain measurement. For many years, tissue tagging was considered the clinical gold standard for validating all the newer strain methods, including the Ecker techniques we'll talk about.
But it wasn't perfect. You mentioned drawbacks, especially for diastole.
Right. The main issue is that those magnetic tags don't last forever. They relax or fade over time during the cardiac cycle.
When does that become a problem?
Specifically in early diastole, the relaxation phase. If a patient has a slower heart rate, the tags can actually disappear before the diastolic filling phase is even complete. That limits our ability to accurately assess that crucial relaxation and untwisting of the heart.
Anyway, around that.
Well, the authors note that using higher field strength magnets, like 3.0 Tesla systems instead of the older 1.5T, can help a bit by making the tags last longer. But it's still a limitation.
Okay, so if tagging was the validation standard, what's the main CMR technique people actually use in clinical practice today?
That would definitely be CMR feature tracking, or FT. It's become really popular mainly because it's much simpler to implement.
How does FT work?
It's essentially a post-processing step applied to the standard Sigma images, the routine bright blood moving pictures of the heart that almost every patient gets during a CMR scan anyway. The software tries to track small image features, mostly focusing on the movement of the inner border of the heart, the endocardial contour.
So it uses existing images, which makes it easier than doing dedicated tagging sequences.
Exactly. Speed and simplicity are the big advantages. Tagging needs special pulse sequences and often complex, time-consuming post-processing. FT leverages data you already have.
But there must be a trade-off.
There is. The trade-off is generally in accuracy and reproducibility. The source is pretty clear that feature tracking tends to show greater variability and discrepancy when you compare it back to the tissue tagging gold standard.
And what does that mean for clinical use, if it's more variable?
This is really critical. Because of that higher variability, especially when you're trying to track subtle motion differences between small regions of the heart, segmental strain measurements using CMR feature tracking are generally not recommended for routine clinical decision-making.
So use FT for the big picture, the global strain.
Primarily, yes. It's best restricted to global strain assessment. If you need high-fidelity regional or segmental analysis with CMR, tagging is still the reference.
Are there newer CMR techniques trying to bridge this gap, get the accuracy without the fading tags?
Yes, absolutely. The field is moving fast. One promising technique is displacement encoding with stimulated echoes, or DENS. It uses pixel-by-pixel displacement vectors, which gives it higher spatial resolution than tagging. And another one is strain-encoded imaging, often called SENC. This offers potentially superior spatial and temporal resolution. Some research suggests it might even allow for near real-time strain imaging with CMR in the future. These advanced methods are really pushing CMR back towards being the comprehensive strain reference standard.
Okay, let's pivot now to the technique most clinicians use day in, day out, echocardiography or ultrasound. What was the first echo method for strain?
The first attempt was tissue Doppler imaging, or TDI. This was basically a one-dimensional technique that measured the velocity of the tissue movement, not deformation directly, but you could derive strain rate from it.
What was its strength?
Its incredible speed. TDI had a fantastic temporal resolution. We could get frame rates up to 300 or even 400 frames per second. This was actually really good for assessing strain rate and those very short high-speed events like the isovolumic contraction phase before the valve opens.
So if it was so fast, why did the field largely move away from TDI towards the slower 2D speckle tracking method?
The Achilles heel of TDI was that it was highly angle dependent, meaning you had to align the ultrasound beam perfectly parallel to the direction of the muscle motion you were trying to measure. If you were off angle, your measurement was wrong. Trying to do that reliably for multiple segments of the LV wall in different directions was just too time-consuming, very operator-dependent, and ultimately not reproducible enough for routine clinical use.
And that's where 2D speckle tracking echocardiography, or STE, came in and kind of saved the day for clinical echo strain.
Exactly. STE solves the angle problem. It works by tracking the natural acoustic markers within the heart muscle tissue itself, these sort of bright and dark interference patterns that we call speckles.
And these speckles move with the muscle.
Yes, they're intrinsic to the tissue image. Since they move with the tissue, tracking them frame by frame in 2 dimensions allows the software to calculate deformation in multiple directions simultaneously without being dependent on the angle of the ultrasound beam. STE really revolutionized clinical strain imaging.
Why did it take off so much?
Because it offered high feasibility, you can get measurements on most patients. It's robust, it's reproducible, especially for GLS, and it quickly became the standard of care. Table 1 in the review notes, feasibility is high, like 80% to 97%.
But STE isn't perfect either, right? Especially compared to that high speed of TDI you mentioned.
Correct. The main limitation is frame rate. STE typically runs slower, maybe 40 to 80 frames per second in routine practice.
Is that fast enough?
Well, the sources are very clear on this. While 40 to 50 frames per second is generally considered sufficient for measuring the peak systolic strain value, like the main GLS number, that frame rate is entirely insufficient for accurately measuring strain rate or for reliably analyzing those very brief high acceleration events like the isovolumic phases.
So we lose some information compared to TDI.
We lose the reliable strain rate information and the ability to precisely analyze very short-lived events. We also have to deal with standard echo issues, image quality limitations, artifacts like shadowing or dropouts, out-of-plane motion, and the big one we mentioned earlier, vendor dependency.
Right, the different machines giving different numbers.
Exactly. Different manufacturers use their own proprietary tracking algorithms, and historically, this has led to clinically significant variations in the results.
So the bottom line for practice is,
If you're doing a follow-up scan on a patient, maybe monitoring them during chemotherapy, you absolutely must use the same machine or at least the same software brand that was used for the baseline scan.
because the difference between vendors could be bigger than the actual change in the patient.
Potentially, yes. Historical data showed GLS differences could be up to 3.7 percentage points between vendors. If you're looking for that critical 15% relative drop that signifies cardiotoxicity, switching vendors could completely mask it or even create a false positive. Standardization is still a major, major challenge.
Okay, we've laid out the technical hurdles. Now let's talk about why we bother jumping over them. What's the clinical payoff? Why is LV global longitudinal strain fundamentally better, more sensitive for finding mild systolic dysfunction compared to the old standby ejection fraction?
This really is the core message of the review and why strain imaging has become so indispensable in modern cardiology. GLS acts like an early warning system. It picks up problems in conditions like heart failure with preserved EF, HFB-EF, or early valve disease, or during cancer therapy monitoring situations where the LVEF often looks deceptively normal.
And the review breaks down why it's more sensitive into 3 distinct mechanisms.
Yes, 3 really powerful, quite distinct reasons why GLS sees damage before EF does. Understanding these is key.
Let's take the first one, which has to do with the heart structure, subendocardial vulnerability.
Right. This comes down to the anatomy of the heart wall. The muscle fibers that run longitudinally based to apex, the ones that primarily determine GLS, are most concentrated in the subendocardium.
That's the innermost layer, closest to the blood inside the ventricle.
Exactly. And physiologically, that subendocardial layer is the most susceptible to injury, whether it's from reduced blood flow, ischemia, or from inflammation or fibrosis.
Why is that specific layer the weak spot?
Couple of reasons. First, the tiny blood vessels within that inner layer experience the highest crushing pressure during contraction. Second, they're the furthest downstream from the main coronary arteries supplying blood from the outside surface. So when there's any kind of supply-demand mismatch or diffuse damage, the subendocardium tends to suffer first and hardest.
Okay, so the damage starts right where the longitudinal fibers, the GLS fibers, live.
Precisely. So even relatively mild injury quickly impairs the function of those longitudinal fibers, causing GLS to drop. And because all the layers of the heart wall are mechanically connected or tethered, this reduced shortening in that vulnerable inner layer quickly results in a measurable reduction in overall GLS.
Long before the damage is widespread enough to actually reduce the overall volume pumped out, which is what EF measures.
Exactly. EF waits for more global damage. GLS sees the first signs in the most vulnerable location.
Okay, mechanism 2 is about geometry, the geometric impact. The source had a really striking ratio here about how different contractions contribute to volume.
Yeah, this is often the real aha moment for people used to thinking purely in terms of EF. The left ventricle isn't a perfect sphere. It's more like an ellipsoid, longer than it is wide. And simulations have shown something fascinating.
Which is?
That the circumferential contraction, the squeezing motion around the short axis, like tightening that belt, has a massive, disproportionate impact on the calculation of stroke volume and therefore EF.
How disproportionate?
The data cited in the review suggests that circumferential shortening contributes about 67% to the stroke volume, while longitudinal shortening contributes only about 33%.
Wow, 2/3 versus 1/3. So LVEF is mostly measuring the squeeze around the middle, not the shortening from end to end.
That's the key takeaway. LVEF is predominantly a reflection of circumferential function. which means
If a patient has a big drop in longitudinal function, let's say their GLS goes from a healthy -20% down to -12%, which is quite significant because that long axis shortening only accounts for a third of the volume change, the LVEF calculation might barely budge. It could easily stay within the normal range.
precisely. LVEF is inherently insensitive to isolated or early changes in longitudinal function. A clinically important reduction in GLS might only cause a tiny, often still technically normal, dip in EF. This explains why the relationship graphically between GLS and EF is much flatter than the relationship between global circumferential strain and EF.
That makes perfect sense. Okay, and the third mechanism, hypertrophy and pseudonormal function. This sounds important for specific diseases where the heart walls get thick.
Yes, this is crucial for understanding conditions like hypertrophic cardiomyopathy, HCM, or hearts thickened by long-standing high blood pressure, or cardiac amyloidosis, where the walls get thick and stiff. In these ventricles, you have thick walls and often a relatively small internal cavity size.
Right.
So in that situation, even if the muscle fibers themselves are quite impaired and only shorten a tiny absolute amount, that small amount of wall movement can represent a large relative change in the volume of that small cavity.
So the EF percentage looks normal or even supernormal just because the starting volume was small.
Right. Exactly. The EF can be deceptively high, creating this illusion of normal or even hyperdynamic function, while the underlying muscle mechanics are actually severely impaired. GLS cuts through that illusion because GLS measures the tissue deformation directly. A reduced GLS in these hypertrophied hearts confirms that systolic impairment is definitely present, regardless of what the EF number says. This is why strain is often a key diagnostic feature, for instance, in differentiating amyloidosis.
Okay, those three mechanisms really clarify why GLS is superior. But measuring it isn't always straightforward. The sources detail several practical pitfalls. Let's start with foreshortening. What is that?
Foreshortening is a very common imaging error in echo. It happens when you acquire the apical view, the views from the bottom of the heart looking up, but you don't quite capture the true apex. You effectively cut off the bottom tip of the ventricle in your image.
So you're measuring a ventricle that looks shorter than it really is.
Correct. You're using an artificially shorter initial length, L dollars and dollars, in your strain calculation.
And since strain is the percentage change relative to yieldable, if the other level others is artificially small.
The calculated percentage change, the absolute GLS value, will be artificially high or overestimated. This is a significant issue. Foreshortening can inflate the absolute GLS value by maybe 10% to 20% compared to the true value. Getting standardized, non-foreshortened views is absolutely critical for accuracy.
Pitfall number 2, selecting the region of interest, or ROI. This sounds tricky, especially in those thick-walled hearts we just discussed.
The ROI is the area the software actually tracks to calculate strain. You have to tell it which pixels belong to the heart muscle. Now, if you're imaging a hypertrophied thick-walled heart and you draw that ROI too thinly, maybe only tracing the inner endocardial border,
Don't have this.
you can significantly overestimate the absolute GLS. Conversely, if you draw the ROI too broadly and accidentally include bright stationary tissues outside the muscle wall like the pericardium, the sac around the heart, which often looks bright on echo.
Then the software tries to track something that isn't moving.
Right. It essentially tethers the ROI calculation to a non-moving structure, and that will artificially reduce your strain estimates, making the heart look less functional than it is. So careful manual adjustment of the ROI is often needed to ensure you're tracking the full thickness of the moving myocardium and nothing else.
Okay, third critical pitfall, timing. Defining exactly when contraction starts and ends.
Timing is absolutely essential because strain is measured over the cardiac cycle, and we're usually interested in the peak value. And diastole, our zero strain reference point, should ideally correspond to mitral valve closure, MVC.
And end systole.
The point of maximum physiological contraction should correspond to aortic valve closure, AVC. Now, the software often tries to automate this timing using the ECG signal recorded simultaneously.
But ECGs aren't always reliable.
Exactly. If the patient has a conduction delay, like a bundle branch block or any other reason for a distorted QRS complex on their ECG, relying solely on that automated ECG timing can be wrong. You might miss the true point of aortic valve closure.
So what's the solution?
Manual correction. The operator needs to visually confirm the timing of the valve closure events on the echo images themselves, or use Doppler signals, and manually adjust the timing markers in the software if the automated ECG placement is clearly incorrect. If you don't, you risk underestimating the true peak strain.
And the final factor, which really highlights that strain, is a functional measure, not purely contractility, load dependency. Strain values change depending on the pressure the heart is pumping against.
Yes, this is probably one of the most important practical considerations for clinicians interpreting serial strain measurements. Strain is not an intrinsic measure of muscle contractility in isolation. It's sensitive to both preload, filling, and very importantly, afterload, the resistance the heart ejects blood against.
How sensitive.
The review cites a fascinating study. They looked at the effect of mental stress, just having people do stressful mental arithmetic. This caused only a moderate increase in systolic blood pressure, a relatively small increase in afterload. And it significantly reduced GLS, not just in chemotherapy patients being monitored, but also in healthy controls.
Wow. So just being stressed during the scan can lower your GLS reading. That's basically a white coat effect for strain?
Absolutely. It's a perfect example. This study really underscores why clinicians must record the patient's blood pressure at the time of the strain measurement, and they should actively try to avoid stressful communication during the imaging itself.
Because if you see a drop in GLS in a patient you're monitoring,
You first have to ask, did their blood pressure go up significantly compared to the last scan? Was the load different? If the load is comparable, then a relative decline of more than 15% from baseline becomes that key pathological threshold we look for instance, in cardio-oncology. But you always have to account for load dependency when interpreting changes in GLS.
okay, GLS gives us a fantastic window into LV systolic function, but the review pushes beyond that towards understanding the heart's energy use and the function of the other chambers too. Let's start with the myocardial work index. This sounds like where we really get into the heart's efficiency.
Yes, the myocardial work index is a really exciting, relatively recent, non-invasive approach. It cleverly combines two pieces of information, the LV strain we've been measuring, which represents deformation,
hmm
with a non-invasive estimate of the pressure inside the left ventricle during contraction.
How do we estimate LV pressure non-invasively?
We typically use the patient's brachial cuff blood pressure as a surrogate, although we might need to make adjustments in specific conditions like severe aortic stenosis where the cuff pressure doesn't perfectly reflect LV pressure.
And combining pressure and strain gives us.
It allows us to construct a pressure strain loop for each segment, or globally. The area enclosed by that loop represents the external myocardial work performed, usually expressed in units of millimeters of mercury times percent. Hg%.
So it's translating a fundamental physiological concept, pressure volume loops representing work, into a clinically measurable index using strain instead of volume.
Exactly. It brings that energy concept right into the clinic using readily available data.
And this lets us talk about efficiency. How do we separate useful work from wasted effort?
We can break down the total work. Constructive work is defined as the work done by a heart segment while it is actively shortening during systole, essentially, the energy that contributes effectively to ejecting blood.
Okay, that's the good work.
Right. Then there's wasted work. This represents energy that's lost or doesn't contribute to ejection. It's calculated as the work performed on a segment that is paradoxically lengthening during systole or work done after the aortic valve closes.
So, like in a scarred area, the healthy parts contract and stretch the scar tissue. That stretching consumes energy but doesn't help pump blood.
Precisely. That's a classic example of wasted work. And from these, we can calculate myocardial work efficiency, which is simply the ratio of constructive work divided by the sum of constructive and wasted work, usually given as a percentage.
Why is this potentially better than just looking at strain?
Because it incorporates the effect of afterload directly into the measurement, and it uses the strain values measured throughout the entire systolic phase, not just the single peak value. It gives a much richer, more comprehensive picture of the heart's mechanical efficiency under its actual working conditions.
Very interesting. Okay, let's revisit that complex shear strain we mentioned earlier. LV rotation and twist. We know the mechanics apex twists one way, base the other. What's the physiological purpose of this twisting?
That torsional deformation, the ringing motion, is really essential. It serves at least two key functions. First, it helps to distribute the stress and strain more uniformly across the entire thickness of the heart wall during contraction.
Okay, makes sense.
Second, and perhaps even more importantly for the relaxation phase, it acts like winding up a spring. Torsion stores a significant amount of elastic energy within the myocardial tissue during systole.
And that stored energy gets released.
It gets released very rapidly as untwisting or back rotation in early diastole as soon as contraction stops. This rapid untwisting creates a powerful suction effect within the ventricle.
Pulling blood in from the atrium.
Exactly. It significantly contributes to early diastolic filling. So if twist is impaired, diastolic function often suffers as well.
Now, measuring true torsion requires knowing the exact distance between the apical and basal planes, which sounds technically difficult. How do clinicians handle this practically?
You're right. Accurately measuring the longitudinal distance to calculate true torsion can be tricky and variable. Because of those technical limitations, the review suggests a simplification for clinical use.
Which is,
Since the rotation of the apex makes the largest contribution to the overall LV twist value, just measuring apical rotation by itself is often used as a simplified, practical, bedside index of LV twist or torsion in many clinical settings. It's not perfect, but it's more feasible.
okay. Let's move beyond the LV now to the left atrium, or LA. Measuring strain here seems crucial for understanding diastolic function and filling pressures.
Absolutely. The LA isn't just a passive chamber, it plays 3 active roles during the cardiac cycle. It acts as a reservoir, collecting blood from the lungs while the LV contracts. It acts as a conduit, allowing passive blood flow into the LV when the mitral valve opens. And it acts as a pump, actively contracting in late diastole to top off the LV filling.
And LA function is tightly linked to the LV.
Very tightly. LA function, particularly its stiffness and ability to relax, is closely related to the pressure and stiffness of the left ventricle it's trying to fill. So LA strain gives us a window into LV diastolic health.
Which of those 3 LA functions, reservoir, conduit, pump, provides the most reliable strain measurement?
The LA reservoir strain is generally considered the most robust and prognostically valuable parameter. This measures the maximum extent the LA stretches as it fills with blood during LV systole.
How is it defined?
It's defined by the peak positive strain reached by the LA wall, usually around ventricular end systole, relative to its size at end diastole, which is the 0 baseline.
And why is it so useful?
Because the amount the LA can stretch is inversely related to the pressure inside it, which in turn reflects the pressure in the LV at the end of diastole, the filling pressure. So low LA reservoir strain suggests high filling pressures. It's also strongly correlated with LV-GLS, partly because the atrium is physically tethered to the LV at the mitral ring.
Is there a clinical threshold for LA reservoir strain that raises concern?
Yes, several studies suggest that an LA reservoir strain value less than about 18% is a strong indicator of elevated left ventricular filling pressure specifically, suggesting a pulmonary capillary wedge pressure likely greater than 12 millimeter Hg. It's a useful non-invasive marker.
What about the LA pump strain, measuring that active contraction at the end?
LA pump strain measures that late diastolic booster contraction. While it does reflect atrial contractility, it's highly sensitive to the LA afterload, which is the LV filling pressure it's pumping against.
So high filling pressure makes it harder for the LA to pump.
Exactly, which reduces the pump strain value. It's also obviously confounded if the patient has intrinsic atrial muscle disease or atrial myopathy, or if they're in atrial fibrillation where the pump function is completely absent. So while useful, reservoir strain is generally seen as the more stable and reliable parameter for assessing filling pressures.
Okay, let's cover the other main pumping chamber. The right ventricle, or RV. Imaging and assessing the RV is notoriously difficult, right?
It really is. The RV has a complex crescent shape. It wraps around the LV, and its free wall is incredibly thin, typically only 3 to 5 millimeters thick.
So getting good strain measurements is tough.
It requires dedicated effort. You need an RV-focused apical 4-chamber view, optimizing the image specifically for the RV. And you have to be meticulous when drawing the ROI, making sure you only track that thin RV free wall and don't include the septum or surrounding structures.
What's the key metric for RV strain? Global or just the free wall?
The current recommendation is usually to focus on RV free wall longitudinal strain.
Why just the free wall?
Partly because its motion is predominantly longitudinal, and partly because clinically the free wall strain often has a larger absolute magnitude, maybe by about 5 strain units compared to the global RV strain, which includes the septum. This larger value might make it a bit easier to detect changes.
Is there a cutoff for normal RV free wall strain?
The data suggests that an absolute RV free wall strain value less than 20%, ERG megas 18%, EGSU 15%, is highly likely to be abnormal or pathological.
Okay. One last advanced metric mentioned is mechanical dispersion. This sounds like it connects the heart's mechanics to electrical stability and arrhythmia risk. Can you explain that concept?
Yeah, think about it like timing. In a healthy heart, all the different segments of the left ventricle should ideally start and finish their contraction fairly synchronously, working together smoothly.
Like a well-timed engine.
Exactly. But if there's disease like scarring or ischemia, some segments might contract much earlier or much later than others. This heterogeneity in the timing of contraction creates electrical instability.
And mechanical dispersion quantifies this timing difference.
Precisely. It's calculated as the standard deviation, SD, of the time it takes for each individual LV segment to reach its peak shortening strain, measured from a common starting point, usually the Q wave on the ECG.
So a bigger standard deviation means more variation, more dispersion in timing.
Correct. A large SD indicates high heterogeneity or dysynchrony in the contraction timing across the ventricle.
And what's the clinical significance of measuring this?
High mechanical dispersion has been shown to be directly associated with an increased risk for dangerous ventricular arrhythmias in several conditions, things like long QT syndrome after a heart attack, and in various non-ischemic cardiomyopathies. It seems to offer important predictive information about arrhythmia risk, even beyond what LVEF tells us, by specifically flagging this temporal non-uniformity.
Right, let's tie all these measurements, GLS, work, dispersion, chamber strains, to specific clinical situations, starting with the most common reason people see a cardiologist: myocardial ischemia and infarction, or heart attacks and lack of blood flow. What are the telltale strain patterns here?
Ischemia, or lack of oxygen, disrupts contraction in predictable ways that strain imaging is very sensitive to. You see, first, a simple reduction in the amount of systolic shortening, we call that hypokinesia.
Less contraction.
Right. In more severe or acute cases, the affected segment might not contract at all, or might even bulge outwards during systole, that's dyskinesia. But a third, often more subtle but very characteristic feature is post-systolic shortening, PSS.
Okay, post-systolic shortening. That means the muscle segment is actually contracting after the aortic valve is closed when systole is supposed to be over.
Exactly. The main pumping phase has ended, but this segment is still shortening.
What does that late, out-of-sync contraction signify?
Well, PSS can sometimes be physiological, just reflecting normal elastic recoil after being stretched. However, when it's pathological, related to ischemia, it typically represents one of two things. Either it's delayed active contraction of an ischemic segment that was stunned but finally manages to contract once the high pressure load drops after the valve closes, or it could be passive elastic recoil of a segment that was stretched and lengthened during systole because it couldn't contract properly.
How do you tell the difference between benign and pathological PSS?
The key is context. Pathological PSS almost always follows a segment that had reduced shortening during systole itself. If the systolic strain in that segment was normal, but you see some PSS, it's often benign. But if the systolic shortening was reduced, and then you see PSS, that's a strong indicator of underlying ischemia or dysfunction.
And overall, GLS helps risk stratify these patients.
Yes, definitely. The review notes that GLS provides incremental prognostic information beyond LVEF, particularly for risk assessment in patients who've had an infarct but still have LVEFs above that traditional high-risk cutoff of 35%. Some guidelines even give it a Class 2B recommendation in that setting.
Okay. Next big area, dysynchrony in cardiac resynchronization therapy, CRT. Strain seems tailor-made for assessing timing issues.
It really is. CRT, using specialized pacemakers to resynchronize the heart's contraction, works best when the problem is primarily an electrical conduction delay, like a left bundle branch block, which causes different parts of the ventricle to contract way out of sync.
As opposed
to dysynchrony caused mainly by large areas of scar tissue from a previous heart attack, where the muscles simply can't contract regardless of timing. Strain helps distinguish electrical dysynchrony, which CRT can fix, from mechanical disparity due to scar, which CRT might not help.
You mentioned LBBB. Is there a classic strain pattern you see with that?
Oh, yes. LBBB creates a very characteristic, visually striking pattern on strain imaging. Because the septum, the wall between the ventricles, is activated abnormally early, it contracts very quickly right at the beginning of systole. This causes a brief, sharp downward spike on the septal strain curve, known as the septal flash.
Okay.
Meanwhile, the lateral wall, which is activated very late in LBBB, is actually being stretched passively during this early septal contraction. Then, when the powerful lateral wall finally does contract late in systole, it pulls on the septum, causing the septum to be stretched back outwards. We call this septal rebound stretch.
So flash and rebound stretch.
Exactly. Plus, you often see this kind of rocking or translational motion of the whole apex, sometimes called apical rocking. Strain analysis quantifies this mechanical disorganization beautifully.
And quantifying it helps choose who gets a CRT pacemaker.
Yes, it helps predict response. Specific quantitative strain analyses have been developed. For example, the longitudinal systolic stretch index, which basically sums up the amount of that lateral wall pre-stretch and the septal rebound stretch, has been shown to be highly associated with favorable outcomes, predicting which patients will have positive remodeling of their heart after getting CRT.
Interesting. Any other strain markers for CRT response?
The myocardial work analysis we talked about is also proving useful here. Looking at the difference in myocardial work between the early activated septum and the late activated lateral wall seems to correlate strongly with successful therapy and reverse remodeling. More work difference suggests more potential benefit from resynchronization.
Let's shift to cardiomyopathies, diseases of the heart muscle itself. Strain seems incredibly powerful here for diagnosis and prognosis, especially where EF might be misleading. Let's start with hypertrophic cardiomyopathy, HCM.
Right. HCM is defined by unexplained thickening of the heart walls. And as we discussed with mechanism 3, these patients often have a preserved or even high LVEF, especially early on.
But the muscle isn't actually healthy.
Often not. GLS is typically impaired in HCM, even when EF is normal. And importantly, the areas showing the most severely reduced strain on the maps often correspond directly to the areas of maximal hypertrophy seen on imaging, or areas where CMR shows fibrosis or scarring, late gadolinium enhancement.
And impaired GLS matters in HCM.
It absolutely does. Studies have shown that impaired GLS in HCM patients is a critical marker, associated with an increased risk of developing dangerous ventricular arrhythmias and even sudden cardiac death. It helps stratify risk.
Okay. Now, perhaps the most visually dramatic strain pattern occurs in cardiac amyloidosis.
Yes, this is the textbook example of a pathognomonic strain pattern. Cardiac amyloidosis, where abnormal protein infiltrates the heart muscle, making it stiff and thick, characteristically presents with the apical sparing pattern on longitudinal strain maps.
What does that look like?
It's striking. The strain values in the basal and mid segments of the LV are severely reduced, very poor contraction due to the heavy amyloid infiltration. But, for reasons not fully understood, the strain at the very apex, the bottom tip of the heart, is relatively preserved or spared.
So you see this clear gradient from poor function at the base to better function at the apex.
Exactly. This distinct base to apex gradient is a powerful diagnostic clue, highly specific for amyloidosis.
Are there specific strain-related red flags and guidelines for suspecting amyloidosis?
Yes. The guidelines highlight two key findings that should raise a strong suspicion. Seeing that visually distinct apical sparing pattern on the strain map, and also calculating an EF-GLS ratio. If the LVEF divided by the absolute value of GLS is greater than 5, that's another significant red flag. Seeing either of these should prompt immediate further testing for amyloidosis.
What about other infiltrative diseases like Fabry disease?
Fabry disease is another inherited storage disorder that can affect the heart. The key point with strain in Fabry is often early detection. GLS impairment can sometimes be detected before significant LV hypertrophy even develops.
Any specific pattern?
It often shows reduced strain with post-systolic shortening, frequently localized to the basal and ferolateral segments of the LV wall, which are known to be particularly prone to developing replacement fibrosis in Fabry disease.
And for arrhythmogenic RV cardiomyopathy, ARVC, which primarily affects the right ventricle, strain must be crucial there too.
Absolutely essential, because RV dysfunction is the hallmark, but conventional measures often fail early on. Abnormal RV strain, particularly RV free wall strain, is often one of the very earliest detectable signs of ARVC.
Even before symptoms.
Yes, it can often be detected in asymptomatic individuals who carry the gene for ARVC long before standard RV function parameters like TPSE or FAC become abnormal. Both abnormal RV free wall strain and prolonged RV mechanical dispersion have been associated with future arrhythmic events in ARVC patients, making strain vital for risk stratification and guiding management like ICD placement.
Okay, let's talk cardio-oncology, monitoring heart function during chemotherapy. Strain seems to have become the standard here.
It really has. This is probably one of the clearest, most widely adopted clinical applications of strain imaging today. GLS is recommended in guidelines specifically because it provides that sensitive early warning of potential cardiotoxicity from cancer therapies.
What's the specific threshold they look for?
The key criterion defined in consensus guidelines is a new relative decline in LV-GLS by more than 15% from the patient's baseline measurement before starting therapy.
So it's not an absolute value, but a percentage drop from their own starting point.
Exactly. So if a patient starts with a GLS of negative 20%, a drop to negative 17% would represent a 15% relative decline, 2017-20 to 20.15.
And this matters even if their EF is still technically normal.
Yes, crucially. This 15% relative GLS drop, even if the LVEF remains above 50%, is used to define mild asymptomatic cancer therapy-related cardiovascular dysfunction, or CTRCD.
And finding that mandates action.
It feels as a clinical decision. It prompts the oncology and cardiology teams to discuss adjusting the chemotherapy regimen if possible, or initiating cardioprotective medications like ACE inhibitors or beta blockers to try and prevent further, potentially irreversible damage to the heart muscle. Early detection with GLS is key.
Lastly, valvular heart disease. Let's take severe aortic stenosis, AS, as an example. If a patient has severe narrowing of the aortic valve but their EF is still preserved, why might a clinician use strain to argue for earlier valve replacement surgery?
This really highlights the power of strain to unmask underlying muscle damage despite a normal EF. In severe AS, the LV is under chronic pressure overload, working much harder than normal. Over time, this damages the muscle fibers, especially those vulnerable subendocardial longitudinal fibers.
Even if the EF hasn't dropped yet.
Exactly. Strain imaging, particularly GLS, can detect this early myocardial dysfunction before the EF falls. Delaying intervention until the EF drops often means you've waited too long, and irreversible fibrosis may have set in.
Is there a strain threshold used in asymptomatic severe AS?
While practice varies, the review suggests that an absolute GLS value worse than negative 15%, example 14%, negative 13%, in a patient with asymptomatic severe AS should be considered a marker of significant subclinical dysfunction. Patients below this threshold seem to be at higher risk of developing symptoms, needing hospitalization, or dying prematurely compared to those with better GLS, even if their EF is identical.
So strain helps identify that subgroup within the asymptomatic preserved EF category who are actually already suffering muscle damage and might benefit most from earlier intervention.
Precisely. It helps refine the timing of surgery, aiming to intervene before irreversible myocardial damage occurs.
We've painted a picture of immense diagnostic power with strain imaging. But we need to be realistic and end by discussing the challenges that still limit its universal adoption and perfect standardization. We already hit on vendor dependency pretty hard.
Yes, and it remains the single biggest practical hurdle. As we discussed, those proprietary algorithms mean that strain measurements, especially GLS, show clinically relevant differences between different vendors' echo machines and software packages, and also for CMR feature tracking.
We mentioned GLS differences up to 3.7 percentage points historically. That's huge if you're looking for a 15% relative change.
It absolutely is. And the unavoidable practical consequence is that for reliable serial monitoring of a patient, you simply must use the same vendor's equipment and software version for every follow-up scan. Mixing vendors introduces unacceptable variability.
How is the field trying to fix this standardization problem?
There are ongoing efforts by scientific societies and industry task forces to try and standardize definitions, acquisition protocols, and even aspects of the algorithms. But it's technically very challenging to get completely interchangeable results across different platforms. We also face internal technical challenges, like the idea of layer-specific strain.
Right. Since we know the subendocardium is the most vulnerable layer, it seems logical we'd want to measure its strain separately from the outer layers. Why isn't that standard practice?
It's theoretically appealing, but clinically, layer-specific strain analysis for the LV is generally not recommended for routine use right now. There are a few reasons.
Gotcha.
First, the measurement variability is still quite high, especially given the thinness of the layers and the limits of current image resolution. Second, technically, the radius of curvature of the LV in the long axis is quite large, meaning the actual length difference between the inner and outer layers isn't that dramatic, making it hard to track reliably.
Okay.
And maybe most importantly, the myocardial layers aren't independent, they're mechanically tethered together. Dysfunction in the inner layer is almost immediately reflected, even if slightly attenuated, in the motion of the outer layers. So while research continues, routine clinical layer-specific LV strain isn't quite ready for prime time.
Okay, let's look forward then. What are the exciting future directions that might overcome some of these standardization and resolution issues?
The future looks really promising, driven primarily by two major forces, I'd say. First is the explosion of artificial intelligence and deep learning in medical imaging.
How will AI help with strain?
AI is already making huge strides in automating the tedious and variable step of image segmentation, outlining the heart borders. Fully automated GLS measurements driven by AI have been shown to significantly reduce inter-observer variability and improve reproducibility and efficiency.
So it takes the subjective human factor out of drawing the line.
Largely, yes. And looking further ahead, AI algorithms will likely be developed to integrate strain information directly with other clinical data, ECGs, biomarkers, etc., to provide even more powerful diagnostic and prognostic predictions. AI could be key to unlocking the full potential of strain data.
Okay, AI tackles consistency and interpretation. What about the fundamental limitations of image acquisition, like frame rate?
That's the second major driver, high frame rate imaging. We talked about how current STE frame rates, typically 40/80 high PCs, are too slow for reliable strain rate assessment. But new ultrasound technologies are emerging that can achieve much, much higher frame rates,
How high?
potentially up near those TDI levels, maybe 300, 400 frames per second, or even higher, using techniques like plane wave imaging.
And getting that speed back would be a game changer
Because, as we mentioned, strain rate is thought to be a more direct measure of myocardial contractility than strain itself, less influenced by overall heart motion. Reliable high frame rate strain rate measurements would potentially give us a much purer assessment of muscle function.
what else could high frame rates enable?
It would dramatically improve our ability to analyze those very short-lived cardiac events, like the isovolumic phases, and potentially make strain measurements during stress echocardiography much more robust and reliable. These technological advancements really promise to give us the kind of physiological clarity we've been seeking.
So wrapping this all up, we've seen the incredible detail that strain imaging offers. The real power of GLS seems to lie in its sensitivity, picking up that subtle dysfunction in the vulnerable subendocardial layer, giving us that crucial early warning in everything from chemocardiotoxicity to valve disease.
And providing those specific diagnostic fingerprints like the apical sparing in amyloidosis or the septal flash in LBBB that help us pinpoint complex conditions.
Strain analysis really lets us look beyond just the simple volume change measured by EF.
It really does. It lets us understand the heart's actual mechanical work, its efficiency, how well its different segments are coordinated. It's giving us a far more detailed, a truly physiological fingerprint of cardiac health than we've ever had before, non-invasively.
Thank you for watching The Funnel Effect.